Medical Center and faculty in biomedical informatics at Harvard Medical School. Dr. Bratt completed his undergraduate degree in bioengineering at Stanford University, where he also obtained his medical degree. He then did a surgical residency at Johns Hopkins Hospital, followed by a fellowship in surgical critical care at Brigham and Women's. He also holds a graduate degree in public health and biostats from the London School of Hygiene and Tropical Medicine, which somehow I didn't know before GPT-4 told me about it. Dr. Bratt is the director of the Surgical Informatics Lab, where he leads a team of researchers who develop informatics tools to improve surgical outcomes. His research interests include clinical decision support, machine learning, computer vision, and federated analytics. I have a long history of working with Dr. Bratt on a number of papers, I don't think any of which he's going to tell you about today. But he's, suffice to say, published extensively in a variety of prestigious journals and conferences, received numerous awards and grants for his innovative work. Dr. Bratt is also an entrepreneur and a mentor for digital health startups. He co-founded a machine learning and computer vision company that was recently acquired. He teaches health IT innovation coursework at Harvard Medical School and advises numerous students. Please join me in welcoming Dr. Bratt today.
So where's the clicker? Oh, there it is. Okay. So thanks everybody for coming virtually or in person to see this talk. I'm going to talk a little bit about some of the work that I've been doing, but this talk is going to be more philosophical than it is about any specific research project. My disclosures. I'm a surgeon at BI. I'm also one of the faculty here, and I have a couple of NIH grants specifically. And then as Nathan mentioned, I'm also the co-founder of a company that was acquired a couple of years ago in the computer vision space. I will not be talking at all about any of the work that's related to that company. So as I said, I'm going to talk a little bit about an opinion that I have, kind of broadly speaking, about healthcare and AI in healthcare. I'm going to talk about one small project that I'm working on with some graduate students and fellows in my lab. And then I'm going to kind of expand a little bit about that, kind of the reasoning for this opinion, and maybe just present a couple of ideas that I've been thinking about and kind of bounce them off people to see how they play out. So the big overarching perspective here is that we have this very kind of binary discussion about AI and about models, where we basically talk about a lot about automation, about assistive technologies, which have incredible value, and in fact, a lot of the work that I've done really fits into this category. And then, but there's always really a push towards this idea where we replace the clinician. And in surgery, the most obvious example of this is robotics. You know, people talk about and strive for automated robotic systems that'll do surgery on their own. But what exists in the broad middle, and where I think really the real push to value in healthcare for algorithmic methods are in this collaboration space. And the really interesting thing is people have been using the term co-pilots a lot recently. And so as I've been thinking about this talk, you know, I really put this talk, the title of this talk together, you know, almost a year ago. But really, because of the term, I thought that what I would do is I would focus more on what does a co-pilot actually mean? What does that look like? And what do I think a co-pilot would have to do in order for there to be a true co-pilot-like presentation for AI in healthcare? And so just to kind of give a little bit of background, kind of talk about, see the direction I'm talking about is Garry Kasparov famously lost 2 out of 3 games against against a computer playing chess. And after spending several months feeling sad for himself, he realized that actually this was an incredible opportunity, and he was responsible for building one of the most advanced systems that actually does a new kind of chess, where instead of it playing chess and you playing against the machine, you can do that, but you can also play collaboratively with this algorithm. So as you're about to make a chess move, this thing recommends additional opportunities and additional directions for you to go. And Kasparov actually has this really cool essay where he talks about that it was very humbling to see these machines actually come up with ideas that he had never thought of. And so it wasn't that this machine was actually replacing him, it was making him better by actually helping him understand things that he couldn't understand on his own. And this is actually a really interesting form of collaboration as opposed to this algorithm kind of replacing him. So that overall, he actually believes he plays better chess now than he ever played before. And a lot of people will agree to this, people who are really into chess, will talk about these systems where you can learn new novel ways of playing chess based on these methods. You know, and so he's talking about a co-pilot. So Suchi Saria, friend of the department, also last week was on a panel for on the Oliver Wyman conference, and she talked about the reason why she loves AI is because AI isn't just this tool that is just being used; it has the opportunity to act as a clinician's co-pilot, right? It is when developed appropriately, it actually can work alongside the clinician and cause them to interact with the data in a completely new way. So I highlight alongside because this is actually the key point, right? A lot of the things that we think about are about these tools kind of sitting in providing a very kind of draft version of reality, and then we make decisions around that. But there is an opportunity that exists far beyond that, is actually where the domain for clinical impact exists. And so this is what most people talk about co-pilots. They talk about basically a world where the algorithm does something, plays with data, presents it to a human, and then the human makes a decision, and apparently because of the human's ability to get this data, they can make a better decision. So it turns out that there's quite a bit of work that suggests that that is not as clear-cut a process as you think, and then it turns out even with explainable concepts, data available to the clinician, they still make a ton of mistakes, and this doesn't actually make them better. So having data available to clinicians doesn't necessarily make them better at doing the task. And I'll actually talk about that in a little bit. And of course, I forgot to mention, if anybody has any questions, please feel free to interrupt this talk. I think maybe it'll take about 45 minutes, so you have time to kind of go.
Just one little comment. The more we use the microphone, the more the people online have the chance to follow.
Okay, so can people hear? So you want me to basically stand behind the microphone, is what you're telling me. Is that correct?
I think this will be better for the.
Okay, all right, that sounds good. No problem. So what I think is a more valuable system, and I think this is what people think about, or they can think about as one form of a co-pilot. The system adapts to the inputs of the human. And so the human isn't the last step, they're actually the first step. They're inputting their knowledge, their perception into a system. And based upon that, the system is then building a prediction, building a tool, building an analytics pipeline that allows them to make better decisions. And then that's working in an iterative fashion to actually make both people better. And so it isn't that it's not a draft version of reality that the human then evaluates. It's a system where there's an input in both direction, where human is learning from the system and the system is learning from the human. Now, that's really hard to do. So the work that I'm going to talk about is a much simpler version of that. A scenario where you still are requiring the human as an input to the system, the human perception, the human prior as an input to the system, but then the combination of the data from the human and the algorithm together actually lead to the improved tax performance. And this is actually what I'm going to kind of describe detail of a project we've been doing. But this to me is what a co-pilot actually looks like, is a version of a reality where the human is actually required to be involved in the system. And so why do we, so what this here, this is what I call, and other folks have called this as well, this is a hybrid model. This is a model that is in some ways is multimodal in the sense that it is both taking in human inputs and it's taking in clinical data inputs. And then what it's doing is it's putting those together to make a recommendation or a prediction or something of that sort. So when do we actually want to use these? So the very clear kind of reaction to this would be, there are lots of scenarios where this isn't necessary, where data is perfect, where our knowledge or understanding of the system is equivalent to what the human has. But the reality is that there are lots of examples in clinical medicine where that's not the case. And so from one side, I would say that the reason why we would want to use a hybrid model is sometimes human judgment is predictably wrong. We think we know what we know, but we don't actually know what we know. We make mistakes, and we make more mistakes than we'd like to make, but we don't actually know when we're going to make those mistakes. And then the other thing is we're really good at integrating lots of data, but even we have limitations about the amount of information that we can aggregate. Some of the most attractive work that's been done in EHR AI has been simply to summarize massive amounts of data for the EHR and present it to a human in a summarized fashion. Why is that valuable? Because there's only so much data, there's only so much time that we have to integrate the massive amount of information that we have to then evaluate in order to make any kind of decision. And so many versions of these tools are valuable because what they do is they're able to take data and summarize it or organize it in a way or evaluate in a way that we can't. On the other hand, the reason to actually involve the human is because often machine readable data is sparse in healthcare. There are scenarios, which we'll talk about specifically, where the machine does not have a lot of the data that it would need in order to make any kind of reasonable prediction on the data set. And so if you don't have that data because recorded it or it's not available to the algorithm, then a human is an imperfect but reasonable proxy because it's what we have available to us. And secondly, when there are also scenarios where we have not yet learned how to quantify the critical information that is actually being used to make a decision. So one of the very, very clean examples that I'll talk about in a couple of minutes is when you are evaluating a patient, there's all these things about the color of the patient, about how the patient is moving. That data has not been quantified. And yet that data is clearly valuable in helping us make decisions about how sick the patient is or how well they would tolerate a procedure. So just to be clear, there are lots of these scores. They're not necessarily AI, but there are lots of these scores that exist. We just don't talk about them because what we do is we pseudo-quantify. What we do is we take human perception and we turn it into a scoring system, and then we call it a score. But if you look at many of the most valuable tools that we use in healthcare, many of them actually have a human perception adjustment that is in the actual score itself. So some of the most famous ones, the ASA score, the Wells criteria, the Mayo score, even the NSQIP risk calculator are all versions of data that they're all algorithms that we have access to that we do not, that specifically integrate a human perception element into them. So the example that I'm going to give is I'm going to talk about an analysis of what's happening in the operating room. Okay, so if you look, this system has tremendous amounts of data that is being generated. So there's the stuff that's going on behind the drape. There is, in this case, this is a robotic case that is being set up, at least laparoscopically. And then there's the robot data. And there's all kinds of data. There's even cameras in the corner of the room. So this is the best version of the data that we have access to. Now, even in this scenario, there are a lot of elements about how a person is operating or what's happening in the room that is not captured in a machine. Okay? A lot of the things that are happening in here are not available to any kind of data system at the moment. But the majority of surgeries in the world don't look like this at all. There isn't this machine here. This data back here isn't being recorded. There isn't a camera in the room. A lot of the data is basically, it's a black box using a totally overused terminology. But what's happening in the operating room is well understood to essentially be hidden from availability to a machine because we haven't quantified. Now, that doesn't mean it's not quantifiable.
It's just the data is super sparse from what happened in the operating room because of because of the systems that we have access to at the moment. And so what do? How do you use that data? How do you integrate that information into making predictions about what's going to happen to the patient after surgery? Because obviously, if you're operating on a patient and something really bad happens, the likelihood that they're going to have a bad outcome is much higher. Like, no one is going to dispute this. But yet, none of the algorithms, none of the prediction algorithms that we have available to us, that I have available to me, specifically addresses that concern. Now, there are some efforts to actually address this, but generally speaking, we make decisions based on the preoperative risk profile that exists for a patient. We go to the operating room, we operate on them, and then we continue to manage them based on their preoperative risk profile. And we don't do anything to really integrate what happened in the operating room. And if you think about that, that doesn't actually make sense. But the reason why we do it is because we don't really have an easily organizable way of evaluating what happened in the operating room into the prediction model for the patient. And so this is some work that we've done with some of my research fellows over the last couple of years that I'll talk about that I think is actually. So the NSQIP risk calculator, I mentioned that as an example of one of these algorithms. So this is the National Surgical Quality Improvement Program from the American College of Surgeons. What they did is they have data, they have a registry data on millions of patients. They organize that data and they then present this online. You can easily get this and you get this presentation, a prediction about the patient's 30-day risk of having a complication, their likelihood of death, their likelihood of discharge to a rehab facility, even things like sepsis. But it's fascinating because there's this adjustment, the surgeon adjustment, which is a surgeon intuition, is you put that in to adjust whether you think the algorithm is going to correctly predict or over predict, or mostly under predict the risk of a patient having a complication. Okay, so why is that? Why are we are including this data? And in a few minutes, I'll talk about why I think this even exists. So as one of my fellows and I were talking about this, because we were like, where does this even come from? How is this adjustment even made? And it turns out that it's completely arbitrary. Okay, so the risk profile, the way that the NSQIP does this is basically the algorithm puts together a prediction, and then you as the surgeon says, do you think there's a risk of a complication? And if the answer is a little bit, then it increases it by 1 standard deviation. And if you say a lot, then it increases it by 2 standard deviations. Why a little bit of an increase leads to 1 standard deviation increase in risk or mortality? Who knows? This was just a way for people to effectively address this concern. And so we said, okay, well, let's do something. Let's actually quantify this difference. Okay, it's a very simple idea, right? You have the prediction the model is making, you add the surgeon prediction, and then you see how much more does the mortality of the patient actually increase. Okay, so we wrote this paper up, published this, I guess about 8 months ago. And fundamentally what we showed was that actually similar to studies that had been done 20 years ago, surgeons are worse at making this prediction than the algorithm. Okay, so actually the answer to this question is that the surgeon really shouldn't be making this adjustment at all, because when they do, they actually tend to actually make a mistake. So they actually reduce the performance of the algorithm when they make this adjustment. Now, big asterisks. Go ahead.
Is the adjustment only allowed to be increasing risk, or can you also decrease?
So great point. So as the system currently exists online, it's increase in risk. But that's the big asterisk. The big asterisk is that there are scenarios that are very clear where the clinician is able to say, I know what's going to happen here. So over the entire population, our performance is worse, but there are subpopulations of patients where we're like, that patient's going to be fine. Right. And so you are absolutely correct that if you were to subset the system appropriately, there are probably patients where surgeons are better at making this prediction than the algorithm is. But over the entire population, we're significantly worse than an algorithm at making the prediction. Is the patient going to die within 30 days after surgery, or are they going to have a major complication? All right. So the way that we did this was that we asked a question before surgery. We asked the surgeon to predict whether the risk of morbidity and mortality compared to the risk profile that we presented to them was more, less, or the same. Okay. But while we were doing this, we're like, you know what? Let's do something interesting because I'm curious. We're going to ask them after the surgery, we're going to ask them the same question. And we're going to ask them, did the patient's risk of having a complication go up? Did it stay the same or did it go down? Okay. And so what you're doing is you're taking their intuition after the surgery and you're integrating it again into this analysis. And so what we did was we compared this to registry data over 10,000 patients. This is just a BI. So the data set is relatively small. The preoperative data and the postoperative data, we had about 800 patients. With preoperative data, we have about 500 patients. We're now probably up to about 700 patients. With postoperative data, we basically used a very simple binomial regression model. We can absolutely discuss whether, given what we discussed earlier, whether a Bayesian method might be better. I'll totally leave that for another discussion. But we simply, for the purposes of the papers, we used very simple like logistic regression. And over this data set, interestingly enough, because this was among, a lot of these were among patients that my specialty operates on, these patients did have a significant complication rate. And they did have significant risk before surgery. But you can see that in about 40% of patients, 37% of patients, the surgeons changed their prediction. They said either the risk that went down or it went up. And this is especially important in my specialty because you have these high-risk patients. And so you operate on them, you say, wow, that went really well. The risk just went down. Or you say, wow, the risk just went up. And so you could look at this as a highly enriched population for complications. And so that's why it's good, but it's also appropriately to say, not totally representative of what the average orthopedic surgeon is doing, where they do the same procedure on low-risk patients day in and day out. Okay. And here's what we showed. Okay. So fundamentally, if you just use preoperative clinical data, that means you just look at the registry data. This is approximately what you get. Okay. If you look at our BI data, we're a little bit better based on a more overfit model. If you use our intuition data, that means the surgeon's prediction before the surgery, preoperatively, we're terrible at doing this prediction task. You can see we're much worse than the algorithm. And then we actually get a lot better if you take in the surgeon's prediction task and the clinical data and you put them together, okay? So, but the important thing is if you take the preoperative and postoperative intuition and clinical data, your prediction improves. Now, it's not a gigantic improvement. This is important, but it is an improvement. And what's happening is the surgeon is being asked, was there a problem during the surgery? And the surgeon is then saying, they're not asked that directly. They're being asked a question that implicitly is asking them about this issue. And they're saying yes or no. They're saying either everything went beautifully, or there was a ton of bleeding, or the anastomosis that I tried to make didn't go well, or the patient was just so sick that everything didn't go like we expected it to. Our sense of what's happening obviously is of what's going to happen improves based on what we see in front of us. And so note what's happening here is that this is a scenario where the surgeon's intuition is required in order to make the best version of the algorithm. And so this is an example of these co-pilots, because the surgeon is not being pulled out of the discussion. They're not outside the conversation. They're an inherent part of the discussion, or there is no algorithmic output that is improvement in performance. And this is the key piece of this, is that a true co-pilot-like system it requires the input of the clinician. Because if you don't, then what you're doing is you're not actually creating a true co-pilot-based system, you're creating basically an automation-based system. So why did people change their perceptions? A lot of this was they would operate and they would things would go really well, or they wouldn't go well, or just the anastomosis wouldn't come together the way they expected. But there were other things. The patient would suddenly have a crash in their blood pressure during the case, or they would have tremendous bleeding. All these were elements that affected our perception of what was going to happen to the patient. And so what are we doing now? So we've been running this analysis now for about 2 years. My fellow this year, over the next year, is actually going to spend the rest of her time. We already have the beginnings of a pilot study where what we're going to do is we're going to essentially generate the clinical prediction model, integrate the surgeon's intuition, build a prediction based on that, and then present it to the clinicians as an opportunity for going down a high-risk recovery pathway versus a routine recovery pathway. So, because this is crazy is not totally the word, but this is one of the things that's really interesting about surgery. So we put all of these patients after surgery into enhanced recovery pathways, where it's a standardized protocol for what you do after the surgery. But you can imagine that a certain percentage of patients don't fall into that category. You operate and something goes wrong. Why would you put them into this standard pathway? So it turns out that we still do that. And so what this will allow you to do is, based on the prediction performance, it'll say this patient should not be in the routine recovery pathway. We're going to create risk stratified recovery pathways for patients based on what the surgeon and the clinical algorithm have come together to say. Right? So although this is not the most beautiful version of an AI copilot where there's a back and forth between the algorithm and the clinician, it is at least one where the clinician's input is required in order to make a decision. Okay, so that's a project that we're working on. And now I'm going to talk a little bit about why I think this is actually relevant. Okay. So when I was preparing this talk a few months ago, I saw this on LinkedIn by John Maeda, who's a very famous, he used to be, I believe he was the head of the MIT Media Lab for a while, or he was at the Media Lab, and he's now the head of design at Microsoft. And he was talking about this, and this really struck a chord, because this is, in some ways, the fundamental thing that people find disagreeable, or they find it problematic about the thing that I'm saying, which is my belief, at least for certain types of algorithms, is that the best way to actually improve implementation and improve uptake in certain cases is to actually add friction. And what does that mean? Adding friction means that you require the clinician to actually be involved in the process of coming up with the output of the algorithm. Okay? Ooh. I just lost everything. Okay, good. Okay, so why is that important? So I'm going to take a tiny detour, because this is something that I've been thinking about a lot. Okay, and talk about this fundamental paradox that exists in clinical AI, in the work that people like myself do. Okay, so let's take an algorithm, and that algorithm comes up with a prediction about the likelihood of some bad thing happening to a patient. All right, similar to the NSQIP algorithm or something else. Okay, and that algorithm is telling you this is what you should do. It's saying, based on this piece of data, this is what you as the clinician should change your behavior. Okay, so there are two ways that this can play out. Either the thing that you think, because you're assuming that you're a trained clinician who has an opinion about this patient, either the algorithm is going to tell you something that is concordant with your perspective. The algorithm says things are going poorly, and you're like, yeah, things are definitely going poorly. Okay, and so that's a concordant prediction. And in that case, if that's what happens every time, then what would we say about this? We would say this is not a valuable algorithm, right? This is an algorithm that is doing nothing. It's not adding any value to you as a clinician, because it's telling you something you already know. Okay, so that's what we call, and we wrote a paper that Nathan's on, that I think is a great paper, that's called and being over the shoulder, an algorithm that's looking over the shoulder of the clinician because it's always concordant with the clinician. Okay, so let's take the other version of that scenario where the algorithm says, you know what, this patient's going to be fine, and you as the human are like, no, I don't think so. This guy looks terrible. Okay, so when you have that scenario, there's a thing that's happening here, which is in terms of the prediction task, if the algorithm is better than you at making that prediction, then this is a more valuable scenario. This is why you use the algorithm, right? You're using the algorithm to tell you the scenarios where you're wrong and it's right. Okay, so this discordance is actually the important one, because otherwise, why are you using an algorithm at all? Okay, and yet this is the scenario that is really uncomfortable to any clinician, right? Because we can talk a lot about the elements of how we think about things. The thing that I'm thinking about is we have this whole thing called predictive coding, where when we expect an outcome and we see it, it makes us feel good. And when we expect an outcome and we don't see it, it makes us feel bad. And so this is a scenario where the algorithm is saying your perception, your judgment is wrong. Okay, so inherently, for an algorithm to be valuable, it has to cause you to be uncomfortable. Okay? Because otherwise, why is it valuable? Okay, and so if that is the case, why is it surprising that there's a hesitation among clinicians to adopt these tools? And why is it that every time that these tools make a mistake, clinicians are like, see, these tools suck? It's not, these tools may actually over a population be better than the clinician, but because the clinicians feel this significant discomfort, then they're going to inherently be distrustful of the algorithm. Because why would you suddenly say to yourself, my judgment is not as good as the algorithm? There's a form of cognitive dissonance that you have to overcome in order to get to that. And that doesn't mean that that's not possible. It's certainly possible for people to have a scenario where they actually trust in the algorithm. But that trust may actually lead to certain other kinds of problems that I'll talk about in a second. So it can lead to automation bias. So we talk about this, where this was a really cool paper in BMJ a couple of years ago, where basically they had an algorithm that was predicting the likelihood of renal failure. And so it recommended a management for a patient based on the risk of renal failure. And what they showed was that the risk of death at teaching hospitals, where people had a lot of people looking over the data, was not significantly changed, but the use of this tool actually increased mortality at non-teaching hospitals. Now, we don't know, and there are people who are working actively on trying to figure out why that's the case. But one possibility for why that's the case is that an automation bias, that people are just like, you know what, this is telling me to do this, I'm just going to do this at a non-teaching hospital. And so what was happening was that people are getting worse care. Mortality was actually increasing because people are just following what the algorithm instead of actually using it as a tool to make a better decision. Another one is an explanation bias, right? This paper was just published a few months ago. I think this is such a beautiful example. Okay, so you have an algorithm that basically says this is what you should do. Okay, and then what they did is they actually had radiologists review it, and you can see that if the algorithm was right, basically it made the people who weren't as expert better, and if the algorithm was wrong, it made everybody worse. Okay, so here's the expert, and here's the expert here. If the algorithm tells you the wrong data, the wrong answer, you get the wrong answer more often. Your accuracy goes down. So what that's saying is, even for people, so that system that I talked about, that unilateral system where the draft version of reality fed to the clinician makes a decision and then has an outcome that improves performance, that's not actually necessarily true, because that version of reality, if it's the wrong one, is actually going to worsen the prediction performance of even an expert. And so what this suggests is that the tool has to look different and it has to work differently. It can't just be, it's going to give you a version of reality that could be wrong and you just need to be good enough to figure out whether it's wrong or right. But it has to be a totally different type of tool. And so there's some work that actually I just found out about a couple of weeks ago by a guy named Daniel Weld, who gave a talk at MIT. Beautiful work looking at this idea of complementary performance, that without there being this back and forth between the system and the human, that these co-pilots don't necessarily work. And so a true algorithmic co-pilot has to be one where there is data, there are inputs that come directly from the human in order to adjust the algorithm. And if that's the case, that's the scenario where you have the ability to overcome some of these things, because the clinician has to be involved, had to have basically put their chips down and said, this is what I think is going to happen, before the algorithm actually is able to make a prediction, because it needs the human data as input, okay? Not only does this lead to potentially a better tool, like the one that we described, but also it leads to less cognitive dissonance. And it has a bunch of other secondary characteristics, which I'll talk about in a second. Because in order for these tools to work, you have to change mindset, skill set, then tool set in that order. Dale Sanders, who was at IMO, he was at Health Catalyst, he talks about this. And I actually think this is a great way of describing this, which is you have to change people's mindset. You then have to change their skill set. You have to change their tool set. And so giving them great tools isn't going to make them better unless you help them have a different philosophy about how they have to think about the algorithm. And so if you have a true AI copilot that requires the clinician to be part of the iterative process, to be an input into the model, what you're doing is not only are you potentially avoiding multiple biases, with the caveat that you might be introducing others, of course, but you're also working on preventing the loss of skill that people are worried about in healthcare. And you're also working on addressing the issue of misalignment that often exists if there's a perverse incentive that are opposite between the clinician and the algorithm. Because what's going to happen is you're going to potentially get data, and you're going to get an output that isn't necessarily concordant with what would be the best performance. So, right. So, two last thoughts. So the first one, that when I give versions of this discussion, okay, humans are inconsistent, right? We make mistakes, obviously. So if we make mistakes, then why are we going to build a model that is not as good as it could be by integrating a human that is imperfect? Okay, well, I addressed some of the concerns before, because sometimes we just don't have data. So you either use the human or you have a bad model. But another reason, and on one hand, totally true. Here's this really cool little study that they did a few years back. Bapu Jena published this in New England Journal as a correspondence, where basically he showed that humans have biases. And so even though these people were 2 weeks, one was 2 weeks before their birthday and one was 2 weeks after their birthday, so functionally they're the same human being, the rate of actually doing surgery was substantially lower, because people have this, once somebody turns 80, they're like, oh, they're 80 years old. Okay, so they're too old for surgery, right? And so obviously that's not logical, because there's a continuum here, but nonetheless, that's a reality. But on the other hand, there's work that Brett has done, where basically he's like, look, he's like, on the other hand, a lot of the algorithms that we have available to us are really doing nothing more than just looking at what humans are thinking and then organizing that as data. I actually have seen there are a number of really cool studies that look at, for example, sepsis prediction tools, and how the amount of data that is available for sepsis prediction tools actually defines whether the sepsis prediction tool works, and the amount of data that's available is actually totally related to what the clinician is actually doing. Okay, so this is the other one, which is based on the same ideas. Well, we should be striving for automation. And while I'm totally supportive of this, work that I've done in the past is versions of the same, there are scenarios where that is currently not possible and not something that actually leads to high performance. And if we want true co-pilot, a co-pilot isn't an autopilot, it's a co-pilot. It's a scenario where the system, the algorithms are working in concert with the human, not replacing the human in terms of their function. And so this is a great example, right? This is that epic sepsis algorithm that was really interesting, but because a bunch of hospitals put it into place, it actually turned out to work very poorly. And that's because it didn't it didn't actually work the way it was supposed to, because there were lots of elements about that information that were automated, that needed to be retrained, that needed to have local knowledge. There were all these pieces of the puzzle about local ways in which people behave that actually caused this algorithm to perform poorly. So a couple of final points. Human algorithm collaborations, these co-pilots, okay, they will expand the kinds of questions we can ask and answer. I gave you an example of something where you have the ability to look at data in the OR through the imperfect lens of the human, and you're able to answer questions about how that is going to affect the outcome of the patient, okay? But importantly, this is also giving you the ability to answer questions in a way that is consistent with the thinking of the provider, and integrating in the important knowledge that the providers have available to them that a system may not have. And the other thing that it does is, by making people part of the conversation, by making the human provider part of the conversation, you're giving them a sense that they have some control over what the algorithm is saying. And if that's the case, among the other elements of this, it may actually aid implementation. So despite the fact that if you had asked me a few years ago, what is the best way of thinking about algorithms, is you want to make them as invisible as possible. At the end of the day, there may be a scenario where you actually need to have the human actually take a role in order for this to actually allow for better implementation of the best version of these algorithms. There are lots of things, right? There is decision architecture that exists in all of this space. There are ways in which we can think about this that go way beyond this. But this is a first place to talk about this, which is that it may be that if we truly believe in this idea of the AI copilot, the AI copilot isn't a draft version of reality that is presented to a human. It's actually one that iterates between the two. So as a final thought, a book that I read recently has nothing to do with healthcare, and yet in the end comes to the exact same conclusion, is this idea that we've gone through eras of advancement in AI and in the use of these tools, okay? And what we started was with an era, and honestly, we're still here in a lot of healthcare, is how do we standardize what is actually happening? How do we use data to help us understand even the most basic aspects of care? We move to, and everyone talks about, the potential for automation. How do we actually automate the processes of care? How do we make it so that the clinician doesn't have to enter the same thing 5 times? Because the system just says, okay, if you did it that first time, then you're probably going to have to do it another 3 times, so I'm going to do it automatically. To adaptation, to collaboration, to a co-pilot state where the system is adapting to the inputs from the person, from the clinical provider, so that this is much more of an interactive and system as opposed to one that goes in one direction. If you have any questions, feel free to reach out. I'm always excited to collaborate and love to take any questions that you might have. Thank you.
I have a question. I find this algorithm human co-pilot idea very intriguing. I wonder, when you're talking about adjusting the algorithm or the feedback from the human to the algorithm, I believe that you don't not only mean that you are adjusting the prediction, but you are also providing the feedback to the algorithm itself to retrain it.
Absolutely.
So I'm wondering, in practice, like in the sepsis model, how would that look like? That you would use the human feedback to retrain the algorithm with this knowledge.
Yeah, so let's say, let's take a sepsis algorithm. So this is off the cuff here, but the way that the sepsis algorithm, what it does is it looks at different points in time. And based on when you look at that point in time, you have access to different amounts of data. Right? So if you were to look at the point where the patient walks into the emergency department, let's say, the amount of data you have available to you is
pretty limited. You might have the elements of a note that a clinician has written, but you're not gonna have much else because the clinician is ordering labs, is talking to the family, is looking at the patient, has an appearance, it says, this patient is probably septic, this sounds like a urinary tract infection, right? So if in those kind of data poor scenarios, one way to do this is if you had feedback, let's say the algorithm is already doing this automated thing. This is actually what exists right now. You have sepsis algorithms that are constantly providing a risk prediction for whether the patient has sepsis. Then that you could easily see a feedback loop where as the clinician behaves, as they do tasks, the algorithm is learning what tasks the clinician is doing, and the clinician is giving feedback to the algorithm to say, I think this person has sepsis, right? Because if you look at when the clinician has now prescribed an antibiotic, or when the clinician has actually logged the ICD code for sepsis, that is way, way beyond at the point where the clinician has actually said, I think this patient is septic. And the value of a sepsis algorithm is not to tell you the patient is septic after you've ordered antibiotics, obviously. And yet, to be perfectly clear, often these algorithms, that's the way they work. Their performance is high when the lactate was ordered, the microbiology results were tested, the blood cultures were sent, and fluids were initiated. Okay, that's like literally the clinician saying, this patient is septic, I need to treat this patient. And yet, that person is septic, order antibiotics, right? Like, so what a scenario that has more of a feedback system is you're asking the clinician, you're adding friction, you're asking the clinician to help train the algorithm by saying, is this patient septic, right? And you could easily see where then, based on certain proxy measures of behavior in a data sparse world, you could then like change your algorithmic outputs based on the prediction of the clinician.
So basically, while you're doing the procedure, you record additional data that you use the patient.
As an example, right? As you're caring for the patient, you're asking the clinician, this person, these things happen. Is this patient septic, right? Because your ability as an algorithm to predict sepsis in every patient just because somebody got a lactate is terrible. But if you say, I see a lactate, and I can ask the clinician, is this patient septic? Those two pieces of data are very different than just taking a lactate and doing a prediction, right? These are, I'm not saying anything that's like novel, but what I'm saying is that if you don't, these models, for anybody who's clinical, makes perfect sense, right? Like this is how we think about our world, but yet we don't build our algorithms to take that into account. If we did, they wouldn't be as attractive because now you're working with an imperfect structure, which is the human's perception, which people don't want to work with, and I understand that because I feel that myself. But taking that into account is a source of data that has value. And what we currently do is we try to bypass that as much as we can. Yeah.
There is a question on a question.
I'm not the Zoom, can you
So I think
Robert had a question.
There's a microphone that can be passed around, right?
Robert, I think you would need to unmute yourself.
If there's a microphone to be passed around, I'm happy to do it. Maybe I guess pass this around.
Well, I think we had the English problem, right? Robert wants to ask a question.
thanks. Robert, you want to go ahead?
Yep. Can you guys hear me?
Can you guys hear me?
Yeah. Yes.
Yeah.
So I'm sort of curious about like two questions. It was a great talk. There was one part where, and they're related a little bit, where you were going through some of the model fitting you were doing and telling us about how the AUC changed. And I would love to get your thoughts at some point on how much work do you do in your lab to try to make sure that the model actually fits the data, right? So there's lots of, I can put anything into a logistic regression and get out parameter estimates and make claims about changes in prediction accuracy, but they don't mean anything if the model wasn't actually right. And rather, unfortunately, data science has led us to a world where we seem to often think the hard part is actually getting the estimate, not figuring out whether the model is the same. And then a little bit related to that was the last thing where you were sort of talking about the sepsis model. And I was very curious, in that situation where, clearly there were some challenges with the model but was it that you had the same sort of inputs in the same ranges and they just meant something different physically? Or was it the case that you had, the inputs were in some sense radically different?
I think the question is I question, but it's kind of cutting out a little bit,
The last sentence we're cutting off, yeah.
but tell me if I think your questions are very related, because what you're saying is there something about how we models actually externalize, and then is the lack of externalization or the lack of generalization part of the problem? And the answer is yes. So certainly the work that we've done, we had models that were trained on national data, and we compared it to local data, which is much smaller. So all these models that currently exist are based on data from 700 hospitals in the United States. But the work that we did was very much local data. And I 100% agree that before one would say, these are the best ways to use these models, you would have to test this in different places and different scenarios. The thing that we're doing, which is a poor representation of that currently, is we're testing this in different services. So we started by training this in colorectal surgery and in acute care surgery, and we're trying this in other specialties that have very different workflows than we do to see if it actually, so a way of evaluating whether the weights that you've come up with actually make sense. But it may be that they actually require retraining and that they are, procedure service specific. And that is actually exactly the problem that existed with the sepsis model. The sepsis model, the EPIC sepsis model, was trained on a subset of data. And when it was then generalized to University of Michigan, because it was Karendeep Singh's work that kind of really talked about this, their workflows were very different than the data that they were using to train the model. And so what was happening was the behavior of the clinician meant different things at different institutions. So it's exactly right. It is that element of clinical behavior that actually throws these systems off, and is actually the reason why it's important to actually have humans as part of this process, because we're doing it whether we like it or not. Our models are taking into account what the humans are doing, simply if for no other reason than they're looking at the behaviors of the humans as it relates to the data that we're collecting. So all of this is actually related. And so instead of making it implicit, making it explicit is actually a way for us to actually build models that relate to the kinds of things we care about. I hope that answered your question.
Not just computer scientists would be, what you guys have is actually a data collection problem, right? And that the work you're describing here is, as you mentioned several times, using the physician as the proxy for those data points that we cannot capture right now. You mentioned a few of them, one being the overall appearance of the patient, the amount of bleeding during the operation, how are they moving beforehand, and so on and so forth. So in a more pragmatic view of the world, you'd say, interesting if you want to put more cameras in, and someone's constantly measuring the amount of blood lost in a clinical setting. So I'm wondering to what extent those attempts to increase the quantification of the experience, particularly in the OR, is starting to feel burdensome to you as a practitioner.
That's a really good question. So I think that at the end of the day, there is going to be some of that conflict that's going to exist. But these things are coming, and you are right. I mean, in a perfect world, a perfect algorithm that had access to all the necessary data that defined what actually caused patients to do better or worse would actually be a perfect algorithm, right? In that world, the human really is an imperfect substitute for a perfect algorithm. But that world doesn't exist yet. And because that world doesn't exist, unless one could make efforts to continue to build towards that world, which is totally fair. But at the end of the day, there's going to be an ongoing need for making some judgments and making decisions about the existing characteristics of the world we live in. Now, is that burdensome? The question is yes and no. If we are actually building tools that people believe help them take better care of patients, there are going to be situations where people are going to be okay with it. Now, there are scenarios where even if something will help us take better care of patients, but it adds a huge amount of burden to our workflow, we're not going to be very happy about it. But I think that there's a balance there around what we can build. And if you look at just the way that people, this is why, I mean, this is now the era of co-pilots. If you look at even the way that people are interacting with large language models, that they're much more comfortable having kind of a discussion with the system based on the data that this thing can generate. That you could see a world where that kind of interchange is actually useful to clinicians, right? That the tasks of summarization, the tasks of organization, the task of taking vast amounts of data and organizing them for clinicians are very happy to have that as part of their world. And if they felt that they were actually working with a tool that actually helped them be better, they would actually, I think there are certain scenarios where they would be very open to it.
There are some more comments on the line. There's 3 more minutes. Should we go to these comments? So,
I think there's a comment from Katie. I don't know whether you just want to speak up, Katie.
Hi, Gabriel. It's really nice to see your work evolving over time. Really impressive. I was hoping to hear more about how patients can weigh in, because they obviously can measure things inside of them, which you can't really even get with existing instruments. I wonder in how far they are able, in some situations they might not be able to, but in other cases they might be able to play an active part. Is there a systematic process to engage them in this co-pilot and business?
I had a hard time hearing that. I'm sorry.
So I think she says like.
The question was basically, to what extent are you thinking about ways to integrate the patient's own input, their own perspectives on their health?
Yeah. Oh, really good question.
And also an interest in like how to visualize these loops, you know, like human AI feedback with the patient in the loop. Are there any ways to visualize that?
So there isn't an easy answer to that question right now. I mean, people are building their entire career about even thinking about that question. We've done some work around looking at the consent process and people's understanding and visualization of that. Nils and I have actually written a paper around that. It's very complex, and the reason why it's complex is because the patient's perception of their disease and the clinician's perception of their disease is often very different. Mm-hmm. And not only is it different, but the things that they focus on as it relates to that disease are often very different. And so people care about kind of functional outcomes, about, you know, what their day-to-day existence will be like. And clinicians often care about, you know, will the surgery be successful, and how will it actually take care of the problem that they've actually been asked to address. And there's a lot of that conflict. I have to admit that I think that question is fascinating, but as I find it really hard to even wrap my head around how to build the tools for the patient, because we still have so little understanding about even what disease even means for a patient as it relates to the data that we have available to us clinically. And so doing that kind of work is very complicated. Now, the closest thing that I will say is there's a lot of work that Nathan and I have actually done in the past where we looked at opioid consumption as it relates to post-surgical management. And even doing something as simple as asking a patient how many pills they consumed after surgery is actually something that is very uncommon. And doing that completely changes our understanding of what is the way in which we should be managing patients after a surgical procedure. Because our understanding of what an appropriate prescription is, which was what most work had done, looked at what surgeons and clinicians were prescribing, but not actually looking at what patients were actually consuming. So this is exactly addressing the question you're asking, which is instead of integrating the clinician's view of a disease, integrating the patient's experience with that disease is obviously very important. That was one very simple proxy measure, which was how many pills they consumed. Looking at people's experience with the disease is a complex one, but certainly worthy of addressing.
Thank you.
All right, we are at time, so thank you, Gabe.
Thank you.
Very nice talk. Thank you.